Good morning, colleagues, and a very warm welcome to the TB Think Tank webinar. My name is Priya Subrayan, and I will be your chair for today's session. We are here to discuss a critically important tool in the fight against TB, the National Standard Operating Procedure for the use of digital chest X-ray with artificial intelligence for TB screening. So the development of this SOP represents a significant step towards us standardizing and optimizing our approach to finding missing patients with TB. Today, we have the privilege of hearing from two key experts who were instrumental in this process. Before I hand over to Prof. Labina, I just wanted to provide some context into the journey that this SOP has taken. And when I reflected on, the initial start and the engagements on this SOP, I think it was early in 2023 when we first realized that there were two sets of digital chest X-rays through two funding mechanisms that were actually following different algorithms in screening and diagnosing TB patients. And the idea was to try and harmonize those algorithms so that whether you are running through the digital chest X-ray through one funding mechanisms or another, that the general algorithm was standardized. And a tremendous amount of work has been put in from our task team, our Finding Missing TB Patients task team. We've had a technical working group that was set up specifically for the digital chest X-ray. And if memory serves me correctly, they met around June 2023 to get all the ideas together here in KZN. Then there was a tremendous amount of meetings back and forth, DOH reviews, and final approval came in 2024 on the 18th of June. And again, why are we doing this now? We're doing it because there is more and more digital chest X-ray trucks that are being procured and are being utilized. We want to ensure this information gets out. And I am now going to hand over, and it's my great pleasure to introduce our first speaker, Prof. Labina. She is the Director of Clinical Trials at the Africa Health Research Institute. And most relevantly for today, she's our immediate past chair of the TB Think Tank's Finding Missing Patients with TB task team, which is the very team that led the development of the national algorithm that we're discussing today. Over to you, Prof. Labina.
No, thank you. And I hope you can hear me well. And thank you for the invitation to come and share the results of this about 3 years of work on the development of the digital chest X-ray. I'll try and put on my camera. Hope that can work. And then also share my slides. But if I struggle for bandwidth, I might switch off the camera. So this is a work of many people, and I've not been chosen to present the summary of the SOP, not because I'm an expert, but just because I have been involved in the process from the beginning to the end. And I'm definitely not an expert on digital chest X-ray, but I think I have learned quite a lot through this process and interactions with others on some of the challenges on implementation. So as we know, the World Health Organization for many years now has been recommending since 2021 that many health systems do not wait until people come or present with symptoms, especially if there's a high TB prevalence of 0.5% or higher, but rather the health system should initiate activities to encourage people to access care and to be screened and investigated for TB, not only wait when they are very sick, but rather we have more provider-initiated screening pathway for those that are at risk, those that are exposed, and also those that are asymptomatic. And in South Africa, I think one of the countries most advanced in this aspect of trying to do systematic screening. In our current guidelines on or SOP on screening, we talk about universal testing for people that are at high risk, which is that second group recommended for systematic screening, that they should be investigated at least once a year when they present for primary healthcare services. Those are the people living with HIV, previous TB, and those that are contacts of a person with TB in the last year. And one of the motivations for doing this is that we've looked at our data and we continue to have quite a large number of missing people with TB. This was from the 2024 WHO report. And you can see across all the age groups that there is a proportion that is considered missing or undiagnosed, unnotified, and not initiated on treatment, and the largest number being in males compared to females. And we also know from the prevalence survey that about 50% of the people were also found to have chest X-ray changes and confirmed on lab, some of them, but they did not have symptoms. So if you wait for people to have symptoms, it might be too late. And the chest X-ray provides that advantage that it can detect early TB or asymptomatic TB. And it used to be the mainstay of TB diagnosis for many years until about the 70s when laboratory confirmation became better. And the current advances in technology, the digitization and the AI with computer-aided reading has also increased the use of X-ray. This is just a bit of history, how X-ray was used for TB screening, 1930s to 1960s. There was a big move to increase community screening because suddenly there were better antibiotics that were more effective against TB, and that revolutionized TB management. And it was worth it to make the effort to go find as many people as possible that have TB and put them on treatment. And that's how then the systematic screening, early diagnosis and effective treatment was sort of the order. And there were large campaigns using X-rays, and they will put them on buses, on cars or trains and aeroplanes so that even the most remote communities could have access to this novel diagnostic tool in the 1960s. But there was no data on the impact on TB transmission, because at the same time as this was happening, there was also an improvement in socioeconomic status of the many countries that had a high burden of TB at that time. And we cannot attribute all the end of the epidemic or reduction in their TB cases to just digital chest X-ray. However, it doesn't mean when the WHO issued a recommendation to abandon the large community-based screening in about 1974, X-ray stopped being used. It continues to be used for clinical setting for diagnosis of TB. But the mass campaigns were discouraged mainly because of high cost, logistical challenges, and intra and inter-reader variability. And of course, the laboratory confirmation had also become better, as I initially said. So as South Africa, we also started moving towards using a digital chest X-ray for screening. As Priya has indicated, they were funding under Global Fund and USAID to make this available at some point. But then there was differences in how people were doing it, the algorithms they were following, and it made it difficult to then compare results. And we thought we can develop an SOP that includes both primary healthcare setting and community health setting. But with the implementation of TAT and other activities happening at the primary healthcare setting, it became very difficult to see how to incorporate a digital chest X-ray without increasing traffic and not linking it to clinical care. So in the end, the SOP I'm going to be sharing today is just focusing on community screening. And this is the work of the Finding the Missing People with TB task team over 3 years, extensive consultative and evidence gathering process to get to this SOP. We had quite a large number of colleagues that are involved in various programs who have done the research. We had interviews with SAPRA. We invited the various manufacturers to come and present to the SOP committee, or the people that were writing. And I think we have quite a good SOP for based on the process that was followed and the current evidence we have. So really the goal of why this SOP was done was to standardize and the use of digital chest X-ray and AI technology for TB screening so that we can optimize TB case finding. And the purpose was to outline the inclusion and exclusion criteria in a community setting or community-based program, to also provide some guidance of management and referral recommendations based on the screening information, not denying or ignoring all the other guidelines that are there on treatment initiation, but linking with those as well. And one of the important things with community screening is site selection. The X-ray machine or the mobile unit has to be placed in a high TB burden in communities based on data on your special mapping. And now we even have access to data. If you haven't logged on to the NICD site, I would recommend that you do that. I didn't get as beautifully as I had expected, but I'm hoping it will improve with time. But we can now see which clinics are diagnosing TB and what are the number of sputums that tested positive. So we can have data to say where are the hotspots areas for TB, and maybe those are the ones that need to be targeted with interventions like this. And the aim is to also regularly review to see that the activities adding value and we are getting a high yield in TB case finding. So the target population to be included is really anyone at high risk of TB, including migrant population, seasonal workers. So placing a mobile X-ray unit in a place where there's lots of farms would be a good spot. Also targeting minors. Some of the mines have their own occupational health services programs, but targeting probably ex-miners or where areas, peri-mining communities, adolescents, homeless people, people with substance use disorders, people who in program settings, inmates, old age homes, and of course the informal settlements as well. So those are some of the recommendations, but of course any relevant recent data to show that that area is a TB hotspot area will be a recommendation. Currently, the people not to be included are children under 15 years of age, people who are pregnant, people who are currently on TB treatment, and people who have been screened with the digital chest X-ray in the past 12 months. It's not necessary to do it too frequently unless there's a reason. So this is the algorithm, community screening. And of course, we cannot exclude symptoms in the assessment, but it's more of a parallel progress that you get your symptom screening as well of digital chest X-ray. And depending on the outcomes of the two, then you will be managed accordingly. If the chest X-ray is normal and you do not have any TB symptoms, then the recommendation that you be cancelled appropriately and be informed that you do not have any reason to be concerned about TB at that stage, and no further investigations. However, if the chest X-ray all you have is suggestive of TB or the TB symptoms are present, then it will be important to then collect a sample for TB testing, and hopefully people can be able to produce sputum. But if they are unable to produce sputum even after support and education, then they could be referred to their local clinic for nebulization and also to be given more information on TB. And the one part that we still need more data on is this digital chest X-ray abnormal adder. So TB symptoms absent, the chest X-ray is has other abnormalities, and this will require a clinical assessment to evaluate to say what could be causing the X-ray abnormalities and if there's any other referral or treatments that are required as per clinical assessment. So that is the summary of the algorithm as it currently stands in our SOP. A note is that while this SOP focuses only on digital chest X-ray for TB, it doesn't prevent other diagnostic tools for TB diagnosis, and we will not consider the clinical elements to consider in terms of management and other things. Rather, people should go to the existing other guidelines that included. So I think so. This was changed to 15 years that all people attending to be screened unless they do not qualify by age or pregnant. Community units will target populations that are less likely to present clinics. So maybe we're settings where you can find lots of men, migrant populations, the homeless, as I outlined in the previous slide, of populations to be targeted, and those with poor healthcare access. Throughput will be improved by asking medical history and detailed contact information after participants screen positive by digital chest X-ray or symptom screen. Instead of spending 30 minutes with each person just to ask how they are doing, if they have past medical history, this will only be done in those that are not well. And this is summarized also in the SOP. We have a sort of a flow process that is recommended, that people should register, confirm that they're eligible, screen for TB symptoms, get a consent for digital chest X-ray. If they're eligible, then move to the digital chest X-ray room. And there was a time where some of the partners were using both the electronic form as well as a paper form. Some information you'll hear later. And this registration took much longer than anticipated, and we were not able to reach the 100 X-rays per day per machine as recommended by the manufacturers. So a quick registration process and moving the person to then get their digital chest X-ray as soon as possible. And then based on their results, if abnormal, negative TB symptom screen, and then refer for clinical assessment. If suggestive of TB or they have positive TB screen, then get more information on medical history, maybe offer an HIV test if it's possible, get the sputum collected and get contact information so that the results can be able to be communicated to the participant if necessary. So as much as we have the SOP and the guidelines, some of the research gaps that were noticed with these implementation programs was that optimization for efficiency was a challenge. Many X-ray machines were only operational for about 4 hours in a day, because then the other time they are either moving or setting up, and some of them they spend more time on admin than the actual X-rays. And my colleague Fazana will then share with you some of the work that has been done on optimization in terms of the use of the mobile units. CAT performance in children, we still need more data so that we can then maybe expand the recommendation to a lower age group. And we still need more work and more data on the management of X-ray suggestive of TB, but no bacteriological confirmation, and more data also on the cost effectiveness that is on these mass campaigns using digital chest X-ray. And some of the other high priority research questions that we identified at that time also included ability to rule out TB disease in TAD groups with no symptoms and normal chest X-rays. Is it still necessary to then ask them to give a sputum sensitivity and specificity in children, repeating and increased efficiency in primary healthcare clinics among high-risk populations with TB symptoms? So those are some of the research questions that really, as I said, this work was coming together of many groups of many colleagues in either in the task team as well as provincial TB managers and those that were involved in the various programs that provided digital chest X-ray. And I think I'll stop there and say thank you for hope it was clear.
Thank you. Thank you so much, Prof. In fact, I'd like to recommend that you just keep your slide on and perhaps take us back to the actual algorithm. I see there's a request to please walk through the algorithm a little bit slower so that we also want to make sure that I think they understand clearly the actual how patients are meant to walk through that algorithm. And please, colleagues, if you have any further questions, you can put them in the Q&A. So, Prof, if you can just share that slide of the actual algorithm so we can walk through it. I know you talked to the algorithm, you've also talked to the process flow. And maybe we can do this one a little bit slowly before we move on to the next speaker.
All right. I will go through it again in a non presentation, but more in a trying to teach mode. And let me put it in a PowerPoint presentation. I think the idea was if you have a community member presenting for screening in the community, one of the big concerns that came up was we will not be in a clinic, privacy will not be guaranteed, and there will not be a lot of medical questions asked about risk of TB, living with HIV, and all those things. So all people who walk requesting a digital chest X-ray should be considered for a digital chest X-ray. The priority has to be on where the chest X-ray is located. So if it's located in the right place, the assumption is that anybody who walks through or who requests to be X-rayed is already at high risk. So everybody is considered, no assessment of risk that much, but we do check TB symptoms. Not to say if your TB symptoms are negative, you're not going to get a chest X-ray, but there's a parallel program, you get a chest X-ray and TB symptoms, and then a decision is only made after you have both the chest X-ray and the TB symptom screen to say what do I do, how do I then deal with this person. And if the community member is well, they do not have any TB symptoms and their chest X-ray is also normal after the chest X-ray, then there are no further investigations recommended. This is the first block of the well people. No further investigation, provide confirmation of the screening result, and the person can be released. And this person will then spend the shortest time possible within the X-ray process, because the initial assessment should be a quick registration process, symptom screen, get just chest X-ray done, and if all well, then the person can be released. However, if the chest X-ray has features suggestive of TB, or they do have TB symptoms at the time of assessment, then it's recommended that they get a sputum collected at that chest X-ray facility as well, and more detailed information like contact details and other medical history as feasible, depending on the facilities of the X-ray. And we've also ability to refer them to go to the clinic to get their sputum results from there, or if the X-ray machine knows when they'll be back, arrange for that. But if the person is not able to produce a sputum, the current recommendation is that they should be referred to the clinic for nebulization and possibly coaching, and provided with material and counseling on TB. And the last column deals with the people with abnormal chest X-ray, not suggestive of TB, but other abnormalities, which could be maybe signs of obstructive pulmonary disease, maybe a healed lesion of something, but the X-ray is not normal and the TB symptoms are not present. This person will also need a clinical assessment, a clinician review to see how else the X-ray findings can be explained and what the clinical management that would be recommended. So yeah, I'll stop there and well, summarized.
Thank you so much, Prof. We've got a few questions that are coming up in the Q&A, and I see some are also asking questions in the chat box. But the first question is, the guidelines to note slide refers to age under 10 years not eligible for testing, while the exclusion criteria talks to under 15 years. Which one is applicable?
The 10 years was an error. It's 15 years and older. I think as we were writing, we got one study that showed that 10 to 15 might be suitable. But based on the consultation with the pediatric task team under the TB think tank, it was decided that one study is not enough to put it in an SOP guideline. We need more data.
So you said under 15 is the correct exclusion criteria.
Yes, yes.
Okay, great. Then the next question comes from Simon. How are digital X-rays with features of prior TB, example fibrosis, categorized? Would these fall under suggestive of TB or abnormal other? And I know, Prof, you said that you are not the expert. So if there is any of the other colleagues who have been working with the X-rays that would like to answer that question, please, you're welcome to raise your hands and we'll see if you can unmute. Unless, Prof, you have that answer. So fibrosis, does it fall under abnormal other? Should we come back to that question, Prof. Labina?
Yeah, I think so. Let's come back to it. Maybe somebody else from the X-ray supplier can give us more information on that. But I'm just seeing the one person that says, what is the recommended interval? It's about a year. So one of the things that should be done if somebody got an X-ray is to get a card and give them that indicates the date and the results of their X-ray findings, so that then they can decide if they want to come back.
Sorry, I realized I've been on mute. Apologies. I see there's another question around, is digital chest X-ray necessary if any individual is symptomatic, as they will provide sputum irrespective of the X-ray result? I think that's the same question that Gorang was trying to flag. And maybe Prof. Labina, you can guide us into why we're recommending X-ray for everyone if symptomatics are going to automatically get a sputum test.
Yes, we had long discussions about this, whether we do a sequential screening or a parallel screening. And after long discussions, it was decided that a parallel screen will be better than sequential. Sequential will mean we ask one or I. For example, we can decide we only start with digital chest X-ray and only ask symptoms after the digital chest X-ray, or we start with symptoms and only do digital chest X-rays for those that are symptom negative. But it was decided that based on the high prevalence of asymptomatic TB and the unreliability of symptom screening, it's better to do a parallel screen. So to get both symptom screen and digital chest X-ray, and then make a decision on how to manage that person based on the results of both. And I know some of my colleagues who were involved in those discussions are also online, and if they would like to add to some of the decisions that were made throughout the process, please chime in. Thanks.
Yes, thanks. And I see Elias has joined us. So Elias, I'm just wondering if we can, there was a question, I'm almost certain it is regarded as abnormal, but there was a question around previous TB, such as fibrosis. How is it classified in on the digital chest X-ray? Is it suggestive of TB, or does it fall under abnormal other? Now, if you can just make sure Elias can unmute to be able to answer that. But while Elias is thinking about that question, there's one last question from Emily, Prof. Labina, around pregnant women. Why are pregnant women excluded from digital chest X-ray? I thought WHO had clarified that the risk of maternal TB to mother and child outweighed the small risk of radiation to the child.
I really cannot remember how we got to that decision, but it was clear in the guideline development that pregnancy test will not be a requirement, but if somebody already knows that they are pregnant, it was considered an exclusion criteria.
Thanks. I'm wondering if there's anyone else from the digital chest X-ray technical working group that wants to answer the question around fibrosis. If not, Simon, I think we'll have to get back to you on that one. Oh, Lynette.
Just a second, I am allowing her. Yes, Lynette, you may unmute and go ahead.
Hi, thanks. So just, with regards to that, if it's just fibrosis on its own, or maybe with one other finding that it will then be reported just as abnormal other. But if it's they sort of combined all findings together and with other findings suggestive of TB, then it will be lumped together with suggestive of TB report. So it really depends what else is also on the X-ray.
Thank you, Lynette. I don't know if there's any other comments from your side. I know you've been part of the technical working group and you worked fairly extensively with the digital chest X-ray.
No, nothing specific other than, thanks for the presentation. And I think it's all come together very well, the final document and the final algorithm. So nothing else really to add what's really been said.
Yeah, great. Thanks. And thanks for your contribution as well, Lynette. All right.
Pleasure.
And I think that is, that's all the questions, just from my side, Prof. Labina. So the technology is evolving rapidly. And how has this SOP been designed to be a living document? And what is the envisioned process for updating these algorithms as new evidence emerges or the AI software itself improves? So putting you on the spot here a little bit, but we know that, with technology, it's just evolving so rapidly. And that is the idea, I'm assuming, that we keep this document as a living document, this SOP.
Yes, that's correct. And some of the things included in the SOPs is cut-offs and how they should also be reviewed, and constant communication with the manufacturers, and also embedding some of those research questions that we do not have data on. Was part of that process to say, as we start implementing, we don't, or as we write the SOP, we don't have all the answers, but things might change if we can get more data on this, more data on cost effectiveness, more data on case detections in different scenarios, and more data on how to optimize these tools. So yeah, I think we just need to continue generating more data to be able to optimize our strategy and guidelines. Thanks.
Thank you so much. And yes, indeed, very topical. I know Nawazi circulated for public comment the ultra portable digital chest X-ray notes. So, a lot more is anticipated in this space. Thank you so much, Prof. Labina, and thank you to everyone who's contributed. We're going to now move on to Ms. Farzana Satha, who is our scientist at the TB think tank. And you would have noticed that in addition to the algorithm that was presented, Prof. Labina also presented some process flows. And this was directly from the work that was done by the Lean Institute as part of a small consulting work that was secured through the TB think tank and the funding from the Gates Foundation. And it was really about how we would optimize this very expensive piece of equipment and just to ensure that we are getting the kind of throughput and we are really finding those patients that we are seeking or we're looking for. So I'm going to hand over to Farzana, who will just take you through some of the initial findings from that digital chest X-ray optimizing process. Over to you, Farzana.
Thank you very much, Priya, and thank you for this opportunity. I'm just sharing my slides. All right. So as Priya's mentioned, this work was conducted by the Lean Institute Africa by a Mr. Tepo Topijani. And what we aim to achieve was to basically evaluate the current practices and workflow of digital chest X-rays for TB screening in various settings, and to describe the current digital chest X-ray approaches and practices, including the barriers and facilitators. And what we wanted to do was evaluate throughput metrics to identify bottlenecks and opportunities for optimization. Following this evaluation, the Lean Institute provided recommendations and an implementation plan to optimize the digital chest X-ray process and ultimately increase throughput. So the study design that was used was a time motion study, which was conducted in 8 sites across 5 different provinces. And this work was done from September to October last year. various data sources were used, and this included staff engagement, speaking to staff about the processes that they used, the documents that they use for recording purposes, and the staff were also observed in their daily work, and their steps that they proceeded with during the day was recorded. Previous records were also looked at as part of the data collection. So the metrics from these data sources that were captured included the process times, how long it took for sputum to be collected, how long it took for the chest X-ray to be done, how long it took to capture screening information, how many clients were screened during the day, how long they actually stood in the queues, and their total journey time of each person, which is basically described as the time from their arrival till the time they depart the site. And when the sites were selected, various things were taken into consideration from these 8 sites, and these included the throughput. So we selected sites that had high throughput so that we can take lessons from these, as well as sites with low throughput. And sites also varied by the mode of their operation, whether they were fixed or mobile trucks. So after the data analysis, what the Lean Institute actually found in terms of capacity and targets was that the teams at the various sites typically consisted of 3 core staff members, and this included a radiographer, an enrolled nurse assistant, and a data capture and/or a driver, sometimes one or both of them. And for each site, there were variable daily targets and setup times. And these differed across the different sites. And some sites also tried to reach their daily target of 100 chest X-rays per day by skipping their lunch break, which is something that's obviously unsustainable. So when we look at the process observations, the core processes were similar, but they varied in the sequences or the steps of the combinations or even the tools that were used. And sometimes combining certain steps like registration and screening often increased the wait times. So what I'm displaying on the screen is 4 different sites utilizing different processes, which resulted in different waiting times. And you can see in the orange blocks, it's where the differences lie. Some sites would capture on a register and then capture on a tablet and then proceed to sending the person for an X-ray and giving them results. The alternative was there was an interchange between capturing on a paper screening tool and capturing on a tablet. The third one was where they would actually first register for a sputum, then capture on the tablet, and then conduct the chest X-ray. And then finally, the last example of a process was where they would capture the person on the tablet and then conduct the chest X-ray and give them their results. So among the few sites that we assessed, there were already these marked differences between the processes that were used, which affected the journey times of the patients. So the common waiting trends that were found was that the longest waiting and the queue was at the tablet registration step at the beginning. Waiting for the chest X-ray result had the second longest waiting time, and this was often due to poor connectivity. And the actual digital chest X-ray had the shortest waiting queue and was the fastest process to take place. So the Lean Institute defines waste as any activity that consumes resources but creates no value for the client. And they detected certain wastes in this process. And the first was duplication, whereby the paper screening tools often repeated the questions that were asked on the tablet registration processes. There were transition losses when the team would switch sites, so they would often lose an hour to an hour and a half to packing up the site, driving to a new site, getting to the site and orientating themselves on where to set up, actually setting up, and the formalities of organizing and preparing the stations. The third waste that was identified was manual record keeping, where staff actually had little notebooks to stick barcodes or write down client information. And this was often to allow for following up patients or even collecting information for stats purposes. And finally, there was a lot of queue confusion found. So layout changes and limited seating often disrupted the flow of the patients. In terms of demand and mobilization, throughput was limited by demand, in the sense where there were not enough people arriving at the site for digital chest X-rays. And the client arrival times often dropped after midday. This indicates that there was poor timing or site placement of the trucks. So busy locations and a dedicated mobilization team is essential to improve the throughput. And integration with community health clinics also would improve consistency. So in summary, key findings were that the journey time of the patients had a huge range. It varied between the sites, and it varied from 7 minutes to up to 45 minutes, but this depended on team size and the setup. The longest wait was at the registration, which was on average 37 minutes, and this was due to a dual paper and digital data capture. As I mentioned, the shortest step was the digital chest X-ray image capture, which was just 1 to 2 minutes. And teams with community engagement staff processed and recruited more clients. So key recommendations in terms of the process and the team would be that 2 tablets for registration is ideal, along with 1 person to collect sputum and 1 radiographer. Adding a mobilizer to manage community engagement is essential. Removing paper tools and sharing digital data with provinces. Collecting a sputum only after the chest X-ray to prevent these bottlenecks. Possibly, if resources are sufficient, adding a 3rd tablet at sputum registration would be beneficial, although sometimes not possible. And training on reporting tools would limit duplication, where staff was manually taking down notes where they could automatically download some reports from the digital system. In terms of the demand and targets, assessing the foot traffic before visiting sites would be able to evaluate the demand before actually setting up the mobile truck, avoiding site switches during the day, and adjusting targets specific to each context, which would mean that a maximum of 100 to 150 chest X-rays is doable in a typical day. And finally, to strengthen the integration with the department, as well as partners who are also conducting chest X-rays. In terms of queues, standardizing the layout to avoid clients losing their places in the queues, and trying to maintain batch sizes to less than 10 people in controlled sites, and assigning a queue manager for campaigns or events with multiple partners, or even places where digital screening takes place at schools, for example. So to summarize, as I said, the ideal team structure would be 2 people for registration, 1 person for collecting sputum, and the radiographer. Simplifying the data capture tools and eliminating the paper forms completely. To improve connectivity, perhaps considering the use of an intranet or an offline data sync solution. Engaging the community by strengthening the mobilization and hotspot mapping, and using simple digital or physical systems to manage queues. So in conclusion, what we found was that the digital chest X-ray throughput is hindered by inefficient data capture and variable team support. The tablet registration process is the primary bottleneck, so this can be the starting point that can be looked at for improvements. Demand management is as critical as the technical capacity of the team. Standardizing processes, digital integration, and clear roles would increase throughput. And a consistent target of 100 to 150 screenings per day is achievable with this minimal investment. Thank you.
Thanks. Prasanna, can you just, while we wait for some of the questions in the chat box, tell us what is the process now? So the Lean Institute, they did it at how many sites? Over this, I think it was last year. And what is the plan going forward?
Sure. So this was done across 8 sites in 5 different provinces. Unfortunately, when this evaluation was done, it was the time where the G6 contract was ending. So we left it where Lean Institute provided these recommendations that I shared with you today to the subrecipients that conduct the digital chest X-rays. But with the funding cuts that occurred in January and the end of the GC6 contract, all of these had a bit of a pause. All these implementations of these recommendations were paused. But what we're trying to do now is with the new GC7 contract, we try, and also there would be new subrecipients that would be doing the digital chest X-rays. So it's a new team that were probably unaware of this process optimization that was done. We're trying to look at putting together some training and sensitizing them to these recommendations so that going into this new phase, they can start implementing some of these recommendations along with the SOP algorithm.
Yeah, great. I do see a lot of the implementing partners for the Global Fund on, and I'd like to hear, from them, particularly around the feedback that they got from this process. But I did notice that there is a question around 100 to 100, digital chest X-rays being feasible. Even with 5 minutes per digital chest X-ray, it seems unachievable in an 8-hour day. I don't necessarily know if you have a response to that, but I hear where you're coming from, Sibo, and I think I'm wondering if what they mean is that you've already got these people, you're doing an outreach, you've mobilized, you're getting a constant stream. And if we reduce some of these duplications, you could get as high as 100 at least. I'm not sure also about the 150. There's another question. Is there standard communication and messaging used in mobilization? Did the assessment review that by any chance? I doubt it.
No, but I mean, Elias is very familiar with these, so I don't know if he has some input into some of these questions.
Nawasi, maybe you can see if you can unmute Elias, see if he has anything to contribute. Good
He is
recommendations.
able to talk, Priya. He's a presenter.
Okay, great.
Yeah, I can just unmute.
Go ahead, Prof.
Okay.
Libina.
Yeah, I was going to allow Elias, but I think one of the things that was done to get to that 100 was the actual number of minutes required to perform one digital chest X-ray. If the person just doing X-rays only did that and there was always somebody waiting for the next X-ray, it was feasible. Thanks.
Yeah, no, good point. Elias?
Yes. Yes. Yes, I think also that recommendation for 100 to 150, it has to also consider the context, because some of the units are placed in rural areas where the implementing team has to travel for some hours, maybe 2.5 hours or 2 hours. So how to reach 150 might be dependent on the environment. In areas like in urban areas where they have to move around close areas, so that can be possible. So then there was a question about the standard communication and messaging used in mobilization. Yes, the materials that we are using are departmental materials that have been standardized across the sub-recipients. So yeah, that's what I can say for now. Thanks.
Okay, great. Thank you for that, Elias. And I just see a really good recommendation. It says an extra tablet, totally warranted. I wouldn't support an additional staff member, but maybe possible for people to self-complete registration on a tablet as an option to consider. And then it says if digital chest X-ray and AI takes 2 minutes and you have good flow, you should be able to reach those sorts of numbers as seen in other countries. I think getting to 100 will be good enough for sufficient cost effectiveness. Thanks, Gaurang, for that. I just want to double check if there are any other questions that remain unanswered, but this has been really great engagement. Did you toy with the idea of asking patients to download? Oh, well, I think Panganai had the same idea as Gaurang, which is asking patients to complete the registration while they queue, but getting some of them to fill it out on their phones. I think that's it. Apologies. Is children only excluded from the screening SOP, or they're not eligible for digital chest X-rays at all? I think that's going back to your presentation, Dr. Rabina. Are we excluding children from the screening, or are they not eligible for digital chest X-rays? I can tell you what we did with our one project where we did have children who were going through a digital chest X-ray screen. We had a pediatrician who was also on board that was looking at the screens to diagnose. I know she had recommended that we also do a lateral, because at the moment the current digital chest X-rays and the AI are working off just those APs for better screening, and they were still being reviewed by a pediatrician who could make a diagnosis. But I don't know if you have anything to add, Dr. Libina, or has she left? I think I saw her drop off.
It seems so, Priya. She has dropped off.
Yeah, so no, Karen, I think, yeah, CAD for children are hopefully available next year. No, that's fantastic. So the X-ray would be similar to the kind of X-ray you'd get at the hospital, the digital chest X-ray, but it is really focusing on the AI and the AI not being able to provide, a score. Elias?
Yeah, maybe to respond to that question for children. So for the sake of the SOP, the under 15, they were excluded on the basis of the WHO recommendation for screening, but it can be done for diagnosis. But for screening, no, it's only 15 and above. So as you mentioned that this is a working document, so I think when we get new recommendation from WHO, that will be updated to cater for the children for screening. Thanks, over.
Yes, thank you. And I totally agree. We'll keep this as a living document, and as there more evidence comes, we can update. Are there CBT points? Yes, there are, Janet. Please, if you go up to the chat, you'll be able to click on the link. Thank you, everyone. We're exactly at 1 o'clock. This has been really great engagement. Thank you for attending. Thank you to our speakers and everyone who's contributed. Really appreciate it. Please watch out for emails from Nolwazi on our next webinar. Thank you.